data and value-based healthcare and the collaboration that has been created between the Codman Shoulder Society and Avant-garde Health. I'll let them tell you what Avant-garde Health is, but it's been transformational in my way of thinking. And in a very short period of time, we've been able to do significant studies with large data sets that I think move the needle. And one of the things that I learned when Mohit Bhandari came and talked to us was that most of the evidence that we have is fragile, meaning that the studies are too small and one or two individuals changing the outcome can change the conclusion entirely. And so, you know, if we consider what we do in evidence-based medicine as a basis for this, we don't have the greatest evidence. And I think Avant-garde Health will change that. So I want to introduce Porter Jones, who is with Avant-garde Health, and Derek Haas, who is the founder and CEO of Avant-garde, and I'll let them take it from here. Derek, can you hear me and see me?
Yes, I can hear and see you, JP.
Perfect, okay. I think, Porter, is Derek going to do the presentation?
He's going to do a quick intro, and then we'll move.
Okay, so I'll let you take it from here, and Derek, go ahead.
Okay, can everybody hear me?
We hear you great.
Yep.
Okay, wonderful. Exciting to be speaking with you all this evening. Really enjoyed the presentations in the first session from Dr. Gerber, Dr. Johnson, and Dr. Adner. And after hearing Dr. Gerber's speech, I certainly had to unbutton and rebutton my shirt a few times here today. So pleasure speaking with you from here in rainy Boston. Wish I could be with you in sunny San Diego here. But unfortunately, unlike all the rest of you, I am not a physician. So stuck here in Boston. But my mother, my father, my brother, my sister are all physicians. And so I've grown up hearing about all the challenges and frustrations that they've been experiencing, trying to deliver high quality care in an increasingly resource constrained environment, as you all have been as well, which was one of the true inspirations behind starting Avant-garde Health in 2014. The other inspiration was beginning early 2013, I started working with Michael Porter and Bob Kaplan at Harvard Business School, co-leading their value-based healthcare research. And so there's so much interest and excitement for people in these concepts. People need software to help them take these ideas and to be successful, implement it in practice in their organizations. And that's where I had back in early 2013, I had the great pleasure of meeting JP. And so it's been fantastic working with and getting to know him over the last decade. And through Avant-garde Health, we're a mission-driven business. Our first and foremost goal is to help physicians, hospitals, health systems, surgery centers to have the insights they need to be able to deliver their care in the highest quality way while doing it as financially optimal as well. And basically what we do through Avant-garde Health in terms of providing lots of kinds of insights is, number one, just help make it as easy as possible for people to find the information they need to be successful in their jobs. And number two, help them understand where are there opportunities to do things in new, innovative, and improved ways, and then help them take those ideas and be successful executing them in practice. And 2 years ago, we started an initiative with JP to bring together a number of different leading shoulder surgeons, going back to our mission of advancing knowledge with the goal of bringing people together to forming a community around different kinds of value-based care insights in shoulder surgery. And so it's been fantastic collaborating with JP, and I'm guessing some of the folks here in the room as well. And with that background, I'll turn it over to my colleague, Porter, who leads the research initiative on our team.
Great, thank you, Derek, appreciate it. So we're going to do a bit of an overview on what the Value-Based Care Shoulder Research Group is, how we've collaborated both with Avant-garde and the Codman Shoulder Society for publications and to drive value in what shoulder surgery is. Wanted to give a very quick overview of where we stand in the market and why we think what we are doing is so important and how this could actually disseminate into other areas of orthopedic surgery and other modalities of surgery in general. This is, as of August 2022, you see that we are rebounding out of COVID, and now let's look at what's going on after. So Kaiser Permanente here locally lost $4.5 billion in 2022. They made $8 billion in 2021, so we're talking about a $12 billion delta during this time. Mass General was the best of the worst right here. So $2.3 billion loss, they made about $442 million the year prior. And Cleveland Clinic, $1.2 billion loss in 2022 and $2.2 billion made the year prior. We know there's a lot of inflationary measures going on. There's a lot of issues that we're having that are outside factors that are driving up cost that is causing this. And let's also not remember, billion is the new million, but this is a lot that we're talking about. We throw around billion, there's new billionaires minted every single day, but it is a lot of money when we're talking about losses in the $8 billion range. Where is a lot of this coming from? So drug prices are up about 36%, labor prices 19%, supply is up by 20%, and we got an average overall increase in cost within the hospital system, within the ASC systems of about 20%. All the while, the reimbursement rates just continue to steadily climb at our annual 3 to 4%. So we've got a couple ways of digging out of this. One way is we can just work harder. We can just perform more services, which, sure, if we're all willing to do that, we can. However, there was, in November of 2021, an article came out, 1 in 5 physicians and 2 in 5 nurses are looking to leave their practice in the next 2 years. A lot of that is the bureaucracy that comes with practicing as a physician. A lot of that comes with the workload, et cetera, et cetera. It costs $1 million for a system to replace a physician that leaves. By the time that physician ramps up in case volume, learns the EHR, learns the ins and outs of that particular hospital or facility, you've lost $1 million until the physician slowly begins to be a revenue generating asset to that healthcare institution. And we have about $4.6 billion in cost to burnout, which is what we see annually, and that has nothing to do with just wanting to leave the profession. So there needs to be different ways to climb out of these losses, the financial implications that we're seeing, rather than just work harder, produce more RVUs, et cetera. So that is where a lot of what we are looking at currently with the Value-Based Care Shoulder Research Group that we do with the Codman Shoulder Society. We want to be looking at costs, we want to be looking at quality, we want to be looking at the overall value that is being provided and produced, both for the hospital, for the patients, and for the physicians. We want to look at all entities that are involved. We got a great group of people that currently work with us. We have 15 surgeons from 10 institutions. Eric, raise your hand. You've been part of the group for a couple years. John Costoros, who I think is possibly left, is also part of it. So we come together monthly. We discuss these topics. What type of ideas do we want to be looking at? And then Avant-garde has an internal team of data analysts, TD-ABC specialists, who crank the numbers, and then we collaborate with the surgeons on the back end to look at the analysis, write the papers, and go to publication. These are 3 of the articles that have been published since August of 2021, a couple based on COVID, and then one based on surgical volume and what that looks like in regards to outcomes. We have 3 more that are already under review. You can see a little bit of the themes that we're looking at as a group. We have put together 6 abstract presentations that have already been submitted, looking at AAOS, AUKUS, and a few other conferences. And then finally, these are the manuscripts in process. And I think what we want to focus on is this latter and bottom portion, looking at TD-ABC for rotator cuff repair, for shoulder arthroplasty, for proximal humerus surgeries. This is the nuts and bolts of the value equation that we're looking at. Being able to actually take institutional data, not just CMS data, but the data from the participants, and actually be able to publish and really look at what is going on. So when we're looking at the data sets and what we actually care about, we're looking at cost and quality. We'll get in a little bit more into the cost and what we actually are utilizing and what we want to produce, not only for research, but also what can be utilized in the day-to-day. And then obviously the quality. No reason to be maximizing profit if the quality goes down and we're not providing the optimal care for the patients. Looking at surgical throughput, how can we be more efficient? I think we've heard one example of how to be more efficient and cost-effective with the surgical trays. These type of ideas, looking at throughput, that is not on our list, but in general throughput. And then also coding. How can you look at coding in a value basis, TDABC, et cetera? This is a typical P&L. Does anybody have P&L responsibilities here? All right, we got a couple. Eric. Typical P&L in any industry can be drilled down, looked at. You have your high-level revenue. Where is that revenue coming from? Where is it generally being generated? And then specifically looking at the cost, how is that in a detailed manner being broken down? Why do we care? It's not just for reporting purposes, it's because that is where we focus our operations. You take this sheet, you understand exactly where your costs are located, how they're subdivided, how you want to attack, be more efficient with those costs, and where do you want to attack and look at the revenue side. But oftentimes we just don't have a very clear level of granularity when it comes to a P&L basis for ASCs, for hospitals, private practices, et cetera. So this is where we want to start and what we look at when we're looking at the research that we're putting together. As you can see on the left side, there's numerous orthopedic procedures. We got total hip replacement, we have shoulder replacements, we have the total case volume, but what is most important here is what is it costing us on a per procedure basis. So you can see your hospital number. This is demo data, but could be slightly representative of what we are seeing. Let's come down to total shoulder replacement, about $11,500 to actually perform and execute one shoulder replacement. So what does that actually include? So this is the TDABC when we're looking at the research projects that we're looking at. That includes two things. It includes the cost of materials. What are we actually utilizing in the OR to actually provide that care to the patient? And then the other direct cost, which is the people. You have to pay the people to actually perform the surgery. So everybody that is involved, from pre-op to post-op to the PACU, everybody that's involved once they get to the floor and inside of the OR. How much time is being dedicated to that patient, and how much money are you having to pay those professionals to provide that time to the patient? And then we want to be able to benchmark. How are you doing, or how are the institutions doing? In our rotator cuff paper, looking at TDABC, that's the crux of it. We want to have, or we're showing institutional data across numerous institutions. What is it actually costing? And then how do they all compare one to another? And what are the differences? Going back to the financial reporting, once we understand the direct costs, we can now calculate our direct contribution margin. But not only are we calculating a direct contribution margin, we're able to do it on a per physician basis. So now we know which physician is most profitable, and how can we mimic the most profitable physician. So you're basically seeing your reimbursement, subtracting out those direct costs that you saw on the previous slide, which are the cost of supplies and the cost of people, and that gives you an idea of what your direct contribution margin is. We love direct contribution margin because these are the items that you as physicians can actually control. If you work at a large institution and they're throwing overhead like magnet certification, JCO certification on your P&L, not much you can do about that, but you can and do have direct oversight on what is being utilized in the OR and the amount of time that's being spent with the patient. So we can see this is real data, cost variations by physician for a particular procedure. So you can see this is one department within a certain institution. I mean, we have one that's costing as high as $11,000 and another group of cases on average that are costing $6,000. You can now also see the breakdown between supply cost, personnel cost, and then the national benchmarks. We find that looking at this data, just having it available, allows everybody to understand. They actually like the comparisons, the clinical staff do. They like to see what they're doing. You can blind it, you can open it up. A lot of institutions will even present this at their service line meetings. It just gives you an idea of where you're at. You don't know what you don't know until you actually have this data. This is a breakdown of how you can look at personnel costs. So again, you can look and see what is being spent just with people on pre-op, surgery, PACU, and post-op. So you can get the actual dollar value and understand what are you spending, but it is also a proxy for time. So I can tell you right here, post-op, $2,000 compared to $345. That particular surgeon, because the post-op personnel cost is so high, just has a high average length of stay. So it's a bit of a proxy for the efficiency metrics. Same thing when you look at the surgery cost. As the surgery cost goes up for personnel, it's OR time. OR time is increasing, or OR time is just more than that particular surgeon's colleagues. So again, it's interesting to know the exact cost and what is actually being attributed to that time, but it is a proxy for what is going on within the hospital. This is a good example of variation of supply. Again, real-world data. This is the differences in supply cost to do the same rotator cuff surgery. So obviously these are averages, but those are per physician looking at their cases and taking an average of that information. So again, when we're looking and doing this type of research, we are very curious about the drastic variation in what is being used and the differences in cost. Some of that can simply just be supply utilization. You're using more than your colleagues, you're doing something different than the colleagues, or it can be just a poorly negotiated price. Either way, you want to be able to dig into it and understand, are we just using too much of something, or have we poorly negotiated, and we want to be able to tell you which one that is. And then finally, we love talking about costs. We need to be financially viable. We're working for a reason. But in the end, you have to be able to look across all of these metrics, how it is affecting outcomes and quality. So as we look through the research that we're doing, we never forget that piece. So it's either patient-reported outcomes or their quality metrics like readmissions, complications, infections, et cetera. We always want to tie it to something. ERAS, if you're using ERAS, is another great metric to look at. As that gets implemented, how is that changing or altering your cost structure? But we want to make sure that that is being associated. So this is a value grid. You can see there is an average cost, this is the cost right here. You have your average line right there, and then patient-reported outcomes on the y-axis. You want to have the highest number of patient-reported outcomes, the highest delta as possible, and obviously be closest to the average or below the average in regards to cost. So we love what's going on here. High patient reported outcomes, well below the average cost. This is something we'd want to dig into, look at the data for all of these cases that particular surgeon is doing. What is going on? What does supply utilization look like? What are the efficiency metrics looking like? What's going on post-op that's providing this type of patient reported outcomes or quality metrics? This individual may need to start mimicking that individual. We got very poor outcomes, a much higher than expected cost. So again, it's just digging into the data, having the available information to actually understand what's going on, looking at what is occurring, how do we mimic, how do we make alterations, and in the end, that is what we're trying to show, that the data provides the roadmap to making changes, the data provides the roadmap to getting better, and giving us the ability to to do our best to get up into that left-hand quadrant. So, of course.
Can you change the physician's behavior by confronting them with the information? Can you repeat that?
Yeah, the question was, can you change the behavior of the physicians by confronting them with the data? Confronting, I think, is a strong word. I mean, I will say that is not necessarily our job. What we have found is if we go back, you see we've got everything blinded. Well, not there, sorry. Everything's blinded here. When we start working with an institution, especially when we're looking at research and getting this information, everyone always says, we want it blinded, keep it blinded. It doesn't take too long, we're talking a matter of months, when they want to unblind it and they actually want to see how they're comparing. And then it tends to come into, they start logging in, they're very curious about their data, they then ask us to help present the data at service line meetings, at Grand Rounds. So we found that just having access to it begins to pique their interest and change their behavior. I wasn't going to show this, but this is a good example. So a lot of the groups love to have their individual patient or physician scorecard sent to them. So this can digitally be created. It's looking at how you compare within your own department, but it is fully blinded. So how many cases did you do, but then what were your all-in costs, and breaking that down to personnel and supply. How did you compare against the best performer? So we've had great success, and we've had a lot of interest in getting to that granularity. And oftentimes they like to then cross-pollinate and ask their colleagues, what are you doing? How are you doing it different than I am? Yep, thank you.
Keep the mic on.
Sure.
So can we bring Derek back on? And I had a few questions, and I can open it to the group here. Great. So a few things come up that I wanted to just highlight that maybe you can clarify, Derek and Porter. It was Bob Kaplan, others had done it before, but said that if you can't measure it, you can't manage it. If you can't manage it, you can't improve it. And one of the things we don't do systematically in the American healthcare system is measure. There's a whole bunch of reasons why there's a motivation not to measure. And one of the things I want you to address is you're measuring cost. But then physicians will argue I'm spending more, but my outcomes are better. That's part one. Part two is there are accounting issues in hospitals. And I found when I looked in the main hospital versus our outpatient surgery center, and you can tell me if I'm wrong here, there was more of a cost averaging approach in the main hospital. And we were able to look at case-based individual cases. We were able to look at margin. To what degree is that an impediment, or can you overcome that? And the other point I want to raise is that to what degree are hospitals willing to partner with physicians who order all the technology that we use and apply it from the standpoint of cost? And how do we align to incentivize cost containment in a way that both participate in the process and there's a reward for both? And again, the last part is how do you deal with the outcomes part of it? I know it's a big bite of the apple and a lot of questions, but I think most people would like to have your answers to that.
Derek, you're on the screen. You wanna give us your thoughts?
Sure. So starting first on the outcomes front, 100% agree with JP that you want to be showing people the full value of their care. So looking at the cost as well as the quality of it in combination. Despite what Porter was just showing in terms of large focus here on the cost side, that's where we see a lot of our, I'd say, kind of like differentiation. But we also, as part of our approach, incorporating as much outcomes data as is potentially available as well. So like in our analytics platform, there's a section around cost, but there's also a section around outcomes where, like, if you're collecting some form of patient-reported outcomes, you can look at that information on its own. You can look at it in combination with the cost data. One of the screens Porter showed was a 2x2 where you could look at cost versus quality of care. And then also we have many dozens of different like ERAS measures that are incorporated into the analytics as well. So you can look at the care processes and try and gain insights that relate to those actions that impact both the cost and quality. And I would say our experience is, it's not, while not universally true, to a great extent, I mean, the types of things that you do to improve quality are the same types of things that you do to improve cost of care, and that just the more consistently you deliver the care, and also the higher the volume that you deliver of that care, the better the quality and the better the costs are. And then in terms of the, I think JP, you're also asking about like, you know, alignment of incentives between physicians and hospitals or health systems. And here too, I mean, there's different ways of approaching this, but philosophically, we're very much of the mind that, I mean, it's important, you know, for improvements to happen that both parties are bought in and excited to be driving those initiatives. And the way we generally speaking, thinking about this is, you know, again, there's a lot of financial pressures as in healthcare today, as many people have touched on. And the typical approach in many healthcare systems is to take a tops-down approach of the administration saying, you know, hey, we're going to be making these changes in, you know, we're basically kind of forcing them upon the physicians. And our general view is like it's much more successful when these initiatives happen collaboratively, where it's like, hey, we have a goal, we need to save whatever X% of costs. Let's collectively figure out the best way to do that and use the data to inform, you know, what are the biggest drivers of cost and where is there ability to save and improve things here that isn't going to adversely impact the outcomes of care. And also, you know, the
Just lost him.
Wi-Fi problem. You want to finish the sentence until he comes back? We can maybe redial that up, but
Oh, there we go.
can you hear us, Derek? We lost you for a minute.
I'm back again. Yeah. Sorry. Can you at least
Say again. We
can
lost.
see
You
you.
have
Can you
a
see me?
slow Wi-Fi.
Okay. Sorry. Maybe I turn over to Porter then, if it's if there's a Wi-Fi issue on my end.
Okay. Porter, do you want to?
Yeah, I think he said it great. That alignment is key, and that comes, you know, it's obviously easiest if the physician is an owner of their facility or they are fully employed. We have also worked and created a framework for gain sharing platforms at hospitals where there isn't an employment, a full employment package. So we try to make sure that it is fully together. And I would also say there is a human element of this, sometimes just knowing what you're spending. We had dinner with a group of neurosurgeons a couple months ago, and we were showing them their spend on BMP. And one was spending an average of $4,500, and the rest were spending an average of $12,000. And he just said, I don't even need to use all of this, but I had no idea how expensive it was. He didn't really have a huge incentive other than just the fact of understanding what was going on to make that cut. But just seeing it and seeing that he was $4,500 compared to $12,000, he decided to make the change. So just having that data and being able to see it in general.
All right.
I think JP, you also had a comment around the cost reporting inside of like hospitals or ASCs and kind of your frustration with that as well. Sorry, would it be helpful to touch upon that, or do you want to go to the question in the audience?
Yeah, Derek, go ahead and touch on that. We're just getting a mic for the question.
Okay. Yeah, I mean, I mean, JP alluded in his intro back to Bob Kaplan. One of his kind of favorite quips is, you know, hospitals have to file these cost reports with CMS each year, and you know, they're hundreds of pages long, and there's only one number that's right in those, and that's the date. And so it kind of goes to the fact that there's no standards around how costs are measured today within healthcare organizations. Literally every different organization has its own unique approach to doing cost accounting. And so one of the things that we're doing through Avant-garde Health is applying a standard cost methodology across each of the organizations we work with called time-driven activity-based costing, which Porter touched upon, TDABC for short. And it allows then for having actually actionable and standardized cost comparisons across organizations, because it really is using the same methodology across places, and it's a methodology that's intuitive for everybody in terms of you basically, the longer you take to deliver the care, the more high cost resources you have involved in delivering the care, the more expensive that care is. And it makes it easy and transparent to understand what to do to achieve improvements and savings with that care delivery as well.
Yeah, thank you. We're going to take a question, Derek, from the audience.
Yeah, my question was about the challenges of accurate, consistent data collection. How much of what you do is manual and how much of it is automated? Because I guess the holy grail is clinicians just treat their patients as best they can, and the data is collected in the background. It doesn't require any extra energy or cost or people to collect that data. So I'd love to know what the mix of manual versus automated is.
Derek, do you want to take
Jordan,
that?
do you want to?
Yeah, I can do it. So the beauty of this is it is essentially all automated. Our platform is not a registry where you're inserting information into it. So once we get the data spec set up, we pull it all from the IT, or the IT department helps us pull that. We're gathering it from different areas, EHR, charge masters, HR department, et cetera, but then we put it all together. So when it finally comes to the administration, the physicians, it is there, it is live, it is accessible. So we want to make it as easy as possible. But yeah, thank you for the question. It's a good question.
How do you collect the time component of that?
Great question. The new EHRs do timestamps. So we're able to take what is the all-in cost, looking at salaries and benefits, et cetera, for that group of professionals, and we're able to then calculate the time spent based on timestamps. So we're able to get that pulled out.
Average then for each individual in that group?
Repeat the question.
Are you using an average
Yeah, so
TDABC per surgeon, per department, or is it?
generally that's the cleanest because we don't want to expose salary information and have people looking. So when you're looking at the TDABC or the personnel costs, we do normalize that. So if your highest paid surgeon is spending the most or the least amount of time, but they're paid the most, that will just show that it's more expensive. We don't want that to be the case. So we want to normalize it to where everyone is being measured against the same standard. And really the only difference, essentially, from nurse to nurse or physician to physician is the time spent.
Does that change between hospital system?
That will change, yes. There's a different pay structure in Boston than there is in
Exactly.
Nebraska. But then when we're doing benchmarking, we will normalize those.
That's my question.
Yes. So Boston will be compared, on a normalized data set across the country based on their information.
I come from a completely different healthcare system, so maybe it's an appropriate question. But if I understood you correctly, you were only looking at the hospital costs. Is that correct? You're looking what the cost is incurred by a hospital.
Correct.
In our healthcare system is so that orthopedic surgery, for our healthcare system, the cost of, for instance, in trauma is about 15% is in the hospital. The rest is disability pensions, it is off work or work leave, sick leave, and we have situations where very expensive hospital treatment is socioeconomically very, very sound. So maybe, can I ask two questions? Number one, so second, I've heard you speak about outcome. Now, the best outcome is if you operate healthy persons, have no problem. The question is, do you in some way look at Delta, at the state of health at entry of the hospital and when they leave the hospital or when the treatment is over, and correlate that with the money that has been spent to obtain this Delta?
Yeah, thank you for the question. So real quick to touch on the first one, this is only measuring the cost of perioperative care. Some of the research we've done with the shoulder group, we will then begin looking at it in a more longitudinal basis and grabbing CMS data. But a lot of what we're looking at here is just the perioperative care. Second question, most definitely is the answer. So we do look at the delta, not just the raw score for the PROMs or the patient-reported outcomes. And remember, we're not collecting these, we are just ingesting that outcome data and then being able to attribute that to other items such as the cost of care that provided. But yes, we're looking at the delta.
Other questions? Sure, hold on one sec. Let me get you the mic.
On your on your value plot, the slope was negative, you know, higher cost, lower outcome. If you averaged all the data you've had so far, is there something there? Is there a trend there? Would it be like noise or Brownian motion, or would it be a positive slope or flat or negative? Is there some trend there?
I'll let
Yeah, I
Derek
mean,
answer that. We've seen a lot more.
There is certainly, like, across different areas we looked at this, not just in shoulder surgery, but range of different clinical areas inside and outside of orthopedics. There is, the vast majority of the time, a positive relationship between care that is lower cost and higher quality at the same time. That it's not that if you're looking at cost versus quality, that you see DOS equally distributed if you're thinking about that as a 2x2 across all four of those quadrants. It is like a fairly significant trend in the direction of, you know, the people who tend to be higher cost tend to be lower quality. The people who tend to be lower cost tend to be higher quality as well. And again, it's a thing of, you know, the people who do things in a more consistent fashion, who do it more frequently, just do a better job overall.
That'd be interesting to explore further.
Yeah, great research idea, thank you.
Oh, wait a minute, hold on. I've got to record you, and I think we'll make this the last question so we can move to the last session.
Just really curious, are you able to look for the effective experience, right? Presumably a new surgeon is going to take longer to do things than someone who's done something 500, 2,000 times?
So we do see that, and I think that, so we can risk stratify, I think is one answer to that. Also with this information, we can go on a case-by-case basis. So you will see some of that. Even with working with JP, he may say, well, I've got a lot of new fellows or residents working with me, and that's why OR time can be a bit longer. But yes, we do see some of that, but we like to be able to identify that so that we can actually map that out and understand what's going on.
I think just to add on to that.
I think,
go ahead, Dave.
just to build off, yeah, I mean, there certainly is like a new surgeon experience curve. I mean, if you're looking at the people, in their first 5 years of practice, that there certainly is a learning curve from an efficiency perspective. And at some point, I don't know the exact number of years, but kind of like in a 5 to 10 year range, it does like you do kind of hit the kind of the maximal learning at that point, and then like it's really a function of the volume of cases that you're performing.
I think it's worthwhile to mention the study that we just had published, looking at, I think it was 150,000 total shoulder replacements, and analyzing surgeon volume relevant to reoperation rates. And unless I'm mistaken, and you correct me if I'm wrong with the numbers, if you take a high volume surgeon and compare it to the lowest volume surgeon, there's about a 4 times higher risk of reoperation.
Right.
Now, the problem with that is, how do we manage learning curves and don't hurt our patients? And we don't really do a good job of that. And furthermore, patients have no idea who's operating on them. This is a major failure, in my opinion, of our healthcare system because the incentives are out of alignment. Can you just comment on that briefly, and maybe we'll make that the last point here?
Yeah, I mean, this is the type of data that we like to have access to and see. I think it's intuitive that the more you do of a particular case, the better you're going to be, the less expensive it's going to be, the better outcomes. But to JP's point, it's not always known what that particular surgeon or department is focusing on, but we do see a significant increase in the outcomes, obviously, of those patients that are being operated on by someone that does 150 to 200 of that procedure per year rather than 10.
Great. Thank you very much, Porter and Derek. Appreciate it.